And then next I'm proud to introduce our speakers here who are going to be talking to us about hearing loss and how it might impact cognition. And first I'm going to introduce Jennifer Smart here in the dress. Jennifer got her BA in speech pathology from the University of Tennessee and then her PhD in clinical audiology from James Madison University. She is an associate professor and program director for the Doctor of Audiology program in the Department of Communication Sciences and Disorders at GVSU. And she has a special interest in auditory processing problems, which maybe we can have her come back and talk to us about it some other time. It's kind of an interesting topic because I don't think it was identified when our children were young, but probably a lot of our children might have had that. Anyway, she has 3 young children at home and she enjoys skiing. And our second presenter today is different. Last week we had Sean here, and this week we have Kara Hotaling. Kara got her BS from SUNY Plattsburgh in New York and an MA from UNC Greensboro, North Carolina, and then her doctorate in audiology from the University of Florida. And Kara is employed as senior clinical faculty and clinical education coordinator at GVSU. And she contributes a lot to the program and will have a lot to share with us today. She also lives in Ada. They all live in Ada. So maybe that's a good place if you have an interest in hearing or something. Anyway, and she has older children who are actually in college mostly. Yeah. High school, senior in high school, going to be in college. So yeah, different groups. And she's so busy being a mom, she doesn't really have any recreational activities at this point, which I get. I mean, that's happened to me too. So anyway, thank you, ladies. We look forward to your presentation.
I'm so happy to see so many familiar faces and new faces. That means we didn't scare you off last time. I want to preface this talk. Dr. Hotaling and I were just chatting about this. We actually have a positive spin on this, right? So there's been some things I think blown out of proportion related to hearing loss and cognitive decline. So we're going to dispel some myths and talk to you in a really positive way about things that we do related to aging and hearing loss and things that we know about cognitive decline, but ways that you can actually sort of head it off or delay. So this will be a good talk, we think. So my background is in auditory processing, which you know, with children and with adults. So we're going to introduce that as a topic. I'd love to come back and have a whole day with you about it. Dr. Hotaling's expertise is in geriatrics. And what was really fun putting this together with her is getting to hear sort of her expertise and how she really integrates that with hearing loss and our considerations for you when we're caring for you. And we have some ideas on how you can get a jump start on if you're having difficulty hearing now, how you can kind of get a jump start on it and things that we can provide at the university to you. This you already know about. That's why you're here. So we're going to cover aging, age-related hearing loss and dementia, and then treatment for hearing loss, because the good news is there are actually a lot of options. And so if you were at the talk that I presented at before, you heard about those, but we're going to kind of talk about how you access those a little bit more today. Okay, I'm going to turn it over to you.
Hopefully I don't yell. I have a really loud voice, so I apologize. So we're not going to talk about anything new regarding aging, but what I want to take a spin on as audiologists, what are the considerations that we take when we look at a patient? So a patient comes in, you've probably heard the term patient-centered care. We really do ascribe by that. And so what are some of the changes that take place in general with aging that we think about when we're taking care of our patients? So just some general thoughts on aging, just, an increased risk of both physical and cognitive decline. We slow down a little bit. I have a cat who is 15 and he's awesome. But I notice, right, he walks up the stairs slower. He sleeps a lot more. He comes down to eat. That's about it. So he's aging, and I see those changes compared to the younger cat. I love my cats. We talk about them. As we age, frequency of the acute conditions that we experience decreases, but chronic increases. Women are more likely to develop one or more chronic conditions, but everything is really variable, right? So individualized. What one person experiences, the next person next to them will experience something completely different. So changes are really variable. But basically, sort of life and aging causes changes. So genetic factors, just normal development, normal changes, the environment, and then also disease or condition. So again, when I go through sort of these next few slides, I'm going to sort of take it to the, as an audiologist, why does this matter to me? And why does it matter that I look at this from my entire patient's perspective? So as we age, our height decreases, so our tendons and ligaments get harder. I'm shrinking. I was 5'4" at my top. Now I'm about 5'3". Those back discs, vertebral discs, thin. So again, we sort of start shrinking down, and then our muscle groups weaken and shrink. Weight loss, so a decline in our muscle mass, right? So muscle weighs more, and with that declining, then our weight tends to decline. I'm still waiting for that. Still waiting for that one. Slight loss is common. But here's, as audiologists, because we see our patients on a fairly regular basis if they are hearing aid patients. And so if a patient comes in and then 6 months later they come in and they've lost a significant amount of weight, that's a red flag for us. That's a concern for us. And it's something that we may follow up on with family member, with the patient themselves. So again, just something for us to keep in mind. And then posture. So sort of along the lines of the tendons and the ligaments and the muscle mass, our posture changes. So in order to stay balanced and upright, this is our center of gravity, right? We are upright over our center of gravity. If we hitch at all over our center of gravity, that increases our risk to falls. And so this is where, again, as audiologists, because we do also assess balance, that is in our scope of practice, it's something for us to consider. Is this patient a risk to falls? Because that's important for us. Oh, I'm doing this, aren't I?
And I do want to just tack on to that because we didn't talk about it last time. Audiologists can assess for balance. And so young people, older adults, so if you're having balance issues and they haven't found a cause for it, you've seen your physician, they're still unsure, sometimes it's your balance system, and you may not know that the audiologist actually can do a comprehensive assessment to identify the problem and potentially recommend rehab therapy. And it gets really confusing. Sometimes doctors just send you straight to therapy without an identification of the cause. But if you have balance issues and they're undiagnosed, or there isn't sort of a cause found, seeing an audiologist can be really helpful. And I didn't mention that last time, and we were talking today, and I was like, oh, I need to make sure that you all know that there are additional resources. And sometimes a diagnosis is really helpful for the purposes of treatment and what's next.
So we'll talk a little bit about movement and exercise and sort of keeping the body healthy with regard to slowing down the cognitive decline. And these changes can make exercise a little bit more challenging, right? So just something, again, to keep in mind. So along the same lines, we get a loss of bone density. Hormones in women are going to make it harder for us, right? So osteoporosis is bone loss. And so that's one change that happens. Collagen becomes more rigid with age, so joints get stiff. So I think arthritis, especially with manual dexterity. So if you have hearing aids, if you've seen hearing aids, they're super little, right? And if you're not using rechargeable batteries, but regular batteries, those batteries are even smaller. So the ability to take care of a hearing aid may be challenging in the event that the patient has arthritis or some sort of struggle with manual dexterity. It's not on here, but interesting fact, cartilage continues to grow as we age. So ears, nose. Okay, that's a total aside. Right.
I promised them good news today.
I know. I love telling these things to students because I'm like, here you go. Strap in, kids. So we also get a decrease in muscle fiber. So again, muscle weighs more than fat. It's replaced with fat tissue. Um, but more importantly, our speed of response slows down. So endurance, um, contraction of those muscles. So once again, exercise, right, becomes a little bit more challenging. And then I mentioned this already. So we just want to ensure that patients are able to care for their hearing aids. They're able to put them in or on, take them off, turn them on, change the battery if needed, change the little earpiece or domes, as we call them. All of those components are really, really tiny. So if we have patients who are very independent, maybe live alone, then we spend a little bit extra time. If there's family members involved in the care, then we bring those family members in. I know when my grandmother was in the nursing facility, she had trouble caring for her hearing aids. So I brought my mom in and said, Mom, here's how you do it. So that way you can take care. They were in New York, so there was a little bit of distance. Okay, the skin. So again, we get a decrease and decline in the number of cells, the elasticity, the thickness. Really, the consequences that, again, as audiologists, we think about are skin becomes more damaged more easily. So, if you've been to have your hearing tested or for hearing aids, we mess around with your ears a lot, right? We look in your ears with the otoscope. We may take an impression of your ear to make the custom molds or earpieces for your hearing aids. So, not that we're not careful, but we have to take extra special care, right, to ensure that we're not damaging the skin surface of our patients. Additionally, the materials that we use for hearing aids, we want something that's a little bit more comfortable and less of a chance of irritation of the skin. So we want to be able to fit our patients comfortably, but effectively as well. Vision changes. So we are ears, but our vision and our sight and our eyes are actually another huge component of both the balance system, but also communication in general. So we use visual cues all the time when we're communicating with people, right? So we hear what they say, but it becomes so much more helpful if we can watch their lips, if we can see facial expressions, body language, gestures. All of that nonverbal information helps us understand what is being said. So in the absence of those visual cues, we then tend to rely on our hearing more. And if our hearing isn't as great as it once was, communication becomes difficult. So things like the changes in in our lenses, letting less light in, darker rooms become more problemsome, right? So I know that, yes, I wear glasses, reading is corrected to 20/20, but if I'm trying to read something that has really small writing, I have to go under a light. And that makes it so much easier for me to be able to see. I bought my husband one of those little, it's a magnifying glass with a light, he keeps it on the table. And again, with balance, vision becomes important. So, do any of you get up in the middle of the night and don't turn lights on? Definitely, right? That could be a falls risk, right? Because we think we know what's in the way. I mentioned I have cats. Sometimes they leave things in the hallway that I'm not expecting, right? So we know that darker environments are difficult, but also it's important for us to be able to see what's ahead of us to help sort of ward off falls. And I mentioned visual cues and navigating our world safely, sort of going there. Okay, changes in the renal system. So we think here about medications. We think about how medications are cleared through the system, and some medications can be harmful to the inner ear, to either the hearing part of the inner ear and or the balance part of the inner ear. So if we have medications that are being prescribed that are cleared through the kidneys and the kidneys are not functioning as they once were, maybe because of disease, maybe not, we just in our heads think about toxicity to the inner ear. So again, when we as audiologists see patients, we want to see their medication list. I'm not a pharmacist. I don't know every single one, but we do sort of know the ones that are our top ones to pay attention to. Same thing, endocrine system. So hormone production changes with age. And that change can definitely impact certain things. So recovery from trauma, adaptation to temperature, mood. We'll talk a little bit later about coping with hearing loss, accepting hearing loss, and advocating. And if we're not in a great mood, our hearing loss may not be something that we want to deal with in that moment, right? So we know that hormone changes can affect that. Additionally, hormone changes, I blame hormones for a lot, but balance could be one of them, right? So just some changes in how we feel in general could impact that. So again, polypharmacy, so multiple medications we have to consider as well. What are the side effects? But also what are the interactions between the medicines that we're on, and what are some of the things that we may see? So dizziness could be one, right? Off balance, but also tinnitus, so that ringing that some of you might have. It's there all the time. It's a high-pitched ring that sometimes is a side effect of medication. In most cases, it comes sort of hand in hand with hearing loss and the damage to the inner ear, but sometimes it is medication. These two, cardiovascular and respiratory system, again, just some different changes to the heart enlarging with age, the stiffness of the valves and the arteries. On the other side, the respiratory system, just again, all of that collagen stiffening, and the weakening of the muscles for respiration. These are going to impact, like we said, that sort of keeping active and exercise, right? So if we're having trouble cardiovascularly or with our respiratory system, that will impact our ability and maybe motivation to keep active. And so again, we'll tie the activity to cognitive decline in a little bit. We have some neurological changes as well. So our learning capacity, the capacity doesn't change. So we still have what we have. It just may take a little bit longer to learn something new, like how to care for a hearing aid, right? Their technology, and they all vary. They're not all the same. They work similarly, but some may have more bells and whistles than others. Some may be more simple and automatic, and some may be more customizable by you. So learning something new just gets a little bit tougher. Memory, so our memory changes a little bit. Short term, long term. It's amazing that I can pull things up from my childhood, but ask me what I did yesterday, and I'm like, I really can't remember what yesterday was, right? But even, when my oldest will be 21 in a little bit, and there are some things that I'm like, I don't remember what, were you born on a Tuesday? I should remember those things. I don't. So using old and new information together, and then motivation. So our motivation may change, right? What's important, what's not important, what's worth it, what's not worth it. Those things change as well.
So I'm going to talk to you a little bit about processing. There's a lot of changes with the brain. We've gone over that, but I want to focus on auditory processing, which is the terminology we use in our field to talk about how we process sound, how we process speech, rate of speech. When I was dialectal differences, when I lived in New Zealand, I could not understand what people were saying. And y'all, it is English. It is English. And they would talk about using the toilet, which Americans don't say. We say bathroom, using the toilet, the lift for the elevator, the motorway, all these words. And I would be like, excuse me, can you repeat yourself? I had no idea what they were talking about in English. Rate of processing is affected by these things, new terminology, how fast someone talks. When I get excited about something, I talk so rapidly. I do often use a lot of slang and sarcasm. So my colleague is from South Korea. I adore him, but sometimes he just stares at me. And then I'm like, okay, we need to just back it up. So there's a lot going on when we're processing, even in younger adults. Auditory processing abilities are impacted by differences in cognitive function. And I mention this because many of you are sitting out there, you have no hearing loss issues, but you may notice that you're having difficulty listening to noise. I don't want to go to, this is me. I don't want to go to a bar at 9 or 10 p.m. on a Friday night. I can't hear anyone. I don't know what they're saying. I don't want to be there. And so these changes are evolving, right? Motivation to be there is also changing. And there's a lot of studies that say, yes, with hearing loss, auditory processing difficulties. That's what we thought. Hearing loss is partnered. But also, auditory processing difficulties may pop up just as a process of aging. You may have perfect hearing thresholds into your 90s, but have difficulty just because of the rate of processing or the different stimuli that you're listening to. There is a study that talks about the rate of auditory processing in older adults. This was done in Australia, and they followed a group of people for a really long time. It's called the Blue Mountain Study, which is really neat because you get a lot of information from following a group of people for a long period of time. Hopkins has a cohort that they've been following as well. But they basically said if we used one of our tests to diagnose auditory processing disorder, the rate would be 76% of the older adults in their study, which is super high. I mean, that's essentially everyone. They're simply highlighting the fact that there are some differences in almost everyone. And that's really important because I want to talk about what we can do to support or I hate to say correction of, but to enhance our ability to process sound, even before we have hearing loss. So if you have hearing difficulties, you should have a hearing test. And we're going to talk about when that should start. Maybe you're having no hearing difficulties and we would still tell you get a hearing test so we know what it looks like. When you have a hearing loss, we're going to recommend hearing aids. We may recommend a cochlear implant. And we'll talk about that in a little bit. But there's also something called oral rehabilitation. And that's kind of like physical therapy for your brain. And in that particular, at least the way I've always structured classes, the way we do at Grand Valley is to teach you good listening strategies, right? So I say to some of my patients, don't go to a busy restaurant at 7:30 on a Friday night, go at 5. It's going to be less busy. Tell them you don't want to be seated by the kitchen. I don't want to be seated by the kitchen, honestly. And then there's some adaptive things we can do, but we have a whole class that just talks about good listening strategies. What should we all be doing to get more out of our environment? And there's also an auditory training program. So there is listening therapy that we can do together, but you can have a computer program that essentially challenges you in listening environments, right? Repeat the sentence that you heard in background noise. And so you're continuing to sort of say to your brain, like, I see what you're doing here, friend, but I am actually going to continue work on this, right? So it's even like lifting 5-pound weights, even if you're already strong, just to keep that muscle growing so that you don't have muscle mass lost. So LACE is the program that I just mentioned. I've actually been following it since its inception. So I think really even when I was still getting my PhD in 05 or 06, it came out. It's evolved as computer technology has evolved, but I actually really like the program. I like it for a range of reasons. You can do it at home. You don't need me. However, I think it's a component of hearing aids and auditory training. I do like the in-person classes. I've been doing them for 20 years and the patients always really like them. They come away with something, especially because we encourage you to bring your partner, communication partner, your neighbor. And so it's really this group setting where we're all learning how to talk to each other better and how to create an environment where we can listen better. So this is just to tell you there's a lot we can do to offset the body's changes, right? And again, you know that all of your physicians would tell you to be doing gentle weightlifting, to be walking with a friend more, right? To maintain these things. I'm just here to tell you, you know what? You can do the same thing for the auditory system.
Okay. Oh, I also want to plug, so Dr. Castillo, if you were here last time, she leads a class for the students in the summer where we host these oral rehabilitation classes for the community. So we can touch on that later, but I sort of want to put a plug out that it's open to any of you. It's free. It is in Grand Rapids, but I think they meet once a week or something like that. So
we can always talk about if a class like that would be appropriate here to bring it to you.
Anyway, just want to put that plug in there. Okay, so some different changes that we experience as we get older that may impact, again, the audiology piece of the patient, but also sort of the cognition as well. And so we know we have life situation factors, right? So maybe we had a whole house full of children and now they're all out of the house. Maybe we retired to Florida, or maybe all of our friends retire to Florida. Is that where people here retire? In New York, it is. Like everybody goes to Florida from New York. So we start to see maybe a little less social contact. Not true for everyone, right? I'm making a very generalization, but that may be true. Where do we live? So do we still live at home, independent? Does somebody live with us? Do we live by ourselves? Are we in assisted living? Are we in a skilled nursing facility? And if we do live in a place where it's not our own home, do we participate in the social events that are offered at some places? I know, again, drawing back to my grandmother, she did have hearing loss. And she did go through a period of time where she was like, yeah, I don't want to eat with any of those people. They annoy me. And I was like, but you have to have some sort of social contact, right? More than just like us or my mom. My mom would go there twice a day. Mental health. So hearing loss can be really aggravating and can cause a lot of negative feelings about oneself or about others, right? So yeah, I'd be able to understand you if you didn't mumble, right? So we know that it can cause some negative feelings. And negative feelings can sort of lead down, I'm not talking clinical depression, but just sort of a depressed mood. Temperament makes a difference. So I talked about this earlier about being able to not only cope with hearing loss, but accept it and then advocate for it. So the ability to say to someone, you need to speak louder because I can't hear you, or you need to face me because I can't, it seems funny. I can't hear you if you don't face me, but it's true, right? Those visual cues. I'm often at my kitchen sink with the water running and my child is upstairs yelling at me. And I say, I hear your mouth is moving. I hear something is coming out of said mouth, but I have no idea what you're saying. You need to come down here, right? So it's not only that they're not in the same room, so distance, they're not facing me because they're not in the same room, and I got background noise that's interfering. So that ability to say, stop talking to me from upstairs, come down here and let's have a conversation. And then again, that level of independence. So are you completely independent? Do you need help with a little, or do you need help with a lot?
And I do want to say that it's really interesting because we do a lot of marriage counseling. We don't charge for it. It's free of cost. Because of exactly what Dr. Hotaling was saying, right? Because, someone in the relationship is frustrated that they can't hear, and they're like, I'm in the kitchen doing dishes and they can't hear me from the other room. And I was like, nobody can hear you. No one. That is not actually them. So yes, marriage counseling is free. So age-related hearing loss, progressive over time. So again, it kind of creeps up on you. It started happening. It progresses over time. Well, Dr. Hotaling is supposed to be doing this, but I'm just going to take over, see what I'm missing. It is a permanent type of hearing loss. So you may hear the audiologist or you may see your report say sensory neural. That means permanent type of hearing loss. High frequencies are affected first, which is why often children, women are harder to hear. It's kind of a joke, but actually women are harder to hear. It's not them, it's you. People may indicate that speech is too soft or muffled. You speak too softly. And maybe you do. Sometimes I do. But maybe also we're starting to lose hearing. You may be able to hear, but not understand. And this was the comment, right? Everybody mumbles. These youths today, they all mumble. Listening and noise may be affected, and our ability to sort of separate out signal versus the interested signal versus other things is affected. And a good signal to noise ratio is always important. So this is something, in fact, on Friday, I'm going into a school system to do this for a young child with normal hearing. So good signal to noise ratio is important for everyone. It gets more impacted with age-related hearing loss. And I mentioned that last point. So we've talked about this and we don't need to go into it more, but if you don't treat your hearing loss, you will start pulling back because you're tired of asking someone what, right? You're tired of saying, can you repeat yourself? You're tired of sitting mahjong. I think I brought this up last time. I don't know what people are doing, but I feel like it's mahjong. I'm making that up. Bunko was cool for a while, but this is what I'm thinking. But it becomes annoying, right? Like to have to say, can you repeat yourself? Can you repeat yourself? And then you just stop talking to people. And then you think, well, why am I going to go? I'm going to miss half the conversation. And so the cognitive decline piece, that last bullet point, is what people latched onto, is that like, oh, if you don't treat your hearing loss, you're going to get dementia, right? Have you heard that? I am like, stop for a minute here. Because if that were true, and we were talking about this the other day, that people who choose American Sign Language, right, who choose to not wear hearing aids from birth or a little bit later in life, who choose ASL would also have dementia, right? Because it is untreated hearing loss. They are deaf. They are choosing American Sign Language. They are not communicating. So I want to be clear on the link, and I want you to feel empowered that there are things you can do with your brain and with your auditory system. It does not mean if you are sitting there thinking, oh, I should have gotten a hearing test, it's fine. It's fine. I'm going to like squash these sort of fear factor. So that leads us into this next section. Okay.
Yeah, I think when Dr. Smart said that to me, she said, if untreated hearing loss equals cognitive decline, then deaf people would all have dementia, and they don't, right? So that's why we're sort of relaying it to the age-related hearing loss. So this case example came out in an article in 2012, which is a number of years ago, but it still is something that I present to the students, is still something that resonates with me. So I'm going to read it to you. And, then we'll talk about it. So Louise is frustrated at her assisted living facility. Menu options are presented aloud in a large, noisy dining hall. It's so noisy, one caregiver always calls out, "Are you hearing me?" Louise, who experiences age-related hearing loss, routinely misunderstands and sometimes misses that she's being spoken to. Then suddenly it seems like the caregiver is yelling at her. But the caregiver assumes Louise is experiencing cognitive decline and makes the meal choices for her. As a result, Louise finds herself served food she dislikes. During a group audiologic rehabilitation session at her care center, which was facilitated by audiology doctoral students from the University of Arizona, Louise explained, "Sometimes I don't eat, I just want to get some food that I like. I want to say, are you hearing me? So we're going to talk about the outward similarities, but essentially the caregivers think Louise is having cognitive decline when in fact she just can't hear them. So these sort of mistakes happen more often than we would like for them to. So here are the similarities, the outward similarities between someone who has cognitive decline or dementia and untreated age-related hearing loss. So compromised social interactions. So we've already talked about that. If you can't hear well, you might just stop doing. You might stop going to play cards with friends. It's too noisy. Can't keep up with the conversation. You may have difficulty remembering information, and that is because you're missing parts of the conversation. So it's almost not even about memory. It's about just not really knowing everything that was said. But it appears that the memory is being affected. Changes in mood or personality. So again, we said it gets aggravating when you can't hear. And it may make us cranky. And it may make us cranky toward ourselves or to those around us. Difficulty with conversations, we've sort of talked about that, and then withdrawal from activities. So both outward look similar. And if we didn't know one or the other, we might mistaken one for the other. So dementia and age-related hearing loss may be mistaken. And so we advocate for annual hearing screenings or tests to begin at age 55. So why? To get a baseline, to say, here is where your hearing is. And as the years go by, we can track hearing. And then all of a sudden, it's not a surprise when we're 65, 70 years old, and we know we have hearing loss. And that is something so that we're not being mistaken for having cognitive decline. It's hearing loss, whether we treat it or not. I am probably our worst patient. I've had my hearing tested twice from the students. They make the sweetest recommendations, very appropriate. And I say to them, I'm not doing it. And they're like, okay.
So quick question, can you go back to that last slide? Well, maybe you're getting to it actually now that you went to another one. We've seen this abbreviation MND/dementia. Can you please explain those three initials for the audience? Thank you.
So I am an advocate for information sharing. I am an advocate for dispelling myths. I am an advocate for not taking a piece of information and running with it. And I really feel strongly that the concept of untreated hearing loss causes dementia has bothered me for a long time. And so I was really excited to do this talk to sort of say what's really going on and dispel some of the myths. But this led to, how do we diagnose dementia? That's the term that's thrown around everywhere. The DSM-5, which came out several years ago, changed it over to major neurocognitive disorder. So MND, that's the term we're going to use. I'm going to leave them sort of paired throughout the talk, but just so that we're all on the same page. They changed it to major neurocognitive disorder, honestly, to be more inclusive. Dementia really has such a negative connotation. And honestly, it's kind of terrifying, right? When we think about it, like, ugh, major neurocognitive disorder. And I want to tell you what that means, because I think, and the diagnosis process, you may be aware of it, but I just want to sort of put it out there so that the negativity and sort of a better understanding. And we have some research that shows you that you really are in control of this in a lot of ways. And that should be empowering. So in order to diagnose major neurocognitive disorder, there needs to be a significant cognitive decline in at least one cognitive domain. So it could be executive function, it could be complex attention, language, learning, memory, which is what we all kind of think of, perceptual, motor, or social cognition. The change has to be different from prior functioning, it has to persist and progress with time. It also needs to impact daily functioning and ability to perform everyday tasks. So physicians who are neurologists, the people who are working with someone suspected of having cognitive decline, should be tracking the patient over time, should be having these. There are screeners that warrant referrals, right? There's a screener that we do, that other people can do, that indicates be evaluated, but it isn't so black and white as it's presented, I think, to the public. This is another one that we really wanted to mention, and I'll let so this is really important, and my mom is experiencing cognitive decline right now, and I think this is such an important piece to this because there are a lot of things that are going to look like a major neurocognitive disorder, but actually be something else. So delirium needs to be ruled out, depression needs to be ruled out, drug use, right? Older people can use drugs. Normal age-associated memory changes, mild cognitive impairment. This comes up a lot, especially in my research area, mild cognitive impairment, and really separating that out from a major neurocognitive disorder. Stress. I can't think about anything when I am stressed or anxious. I can't even come up with common words. And so to make sure, again, we should be seeing this sustainable over time as well. But chronic stress can impair that. Structural brain abnormalities, HIV or neurosyphilis. This is a fun fact and not related, but Baltimore, where I came from, has such a high rate of syphilis that they test you. So, like, if you get a job at Hopkins, they're going to test you to rule out that you don't have syphilis. That is how high the rate of syphilis is, right? Because we're thinking we haven't heard this term in 30 years. Well, Baltimore has books about it. So, I know, just a fun fact. We're going to take this away. Nobody's going to travel to Baltimore. Thiamine deficiency, folic acid deficiency, thyroid disorders, metabolic abnormalities and derangements, medication induced. So back to the polypharmacy. And this is really important because the combination of medications are a big deal. Vitamin E deficiency. When I was in school, we talked about gerontology and gerontologists, right? A specialist physician who focuses on just the aging because you are a special population and there are unique needs. Now, try to find one. Try to find one. Try to find a gerontologist and not wait 64 months to get in there. And right? So there should be doctors we have pediatricians, right? Same things. Real talk, same things. If the American Medical Association is listening now, I am calling you to get this together. So if you had a gerontologist, let's back up. They should know what this looks like. They should be tracking this and they should be looking at this as well. And they should be following your medication to make sure that polypharmacy is not part of the reason you're having memory issues or the reason you're having memory issues. And then, does anyone notice what's missing? Hearing loss is not on this list. You are hearing it first. Hearing loss needs to be ruled out too. And such an easy thing. Medicare covers hearing evaluations once a year. There are audiologists everywhere. We'll get to quality of testing later, but the net out is we're not hiding from you. So there was a whole push with our organizations related to better educating physicians. You know what? I would teach the nurses at general practices to do hearing screenings because we just need to know sooner. We don't need to have age-related hearing loss and cognitive decline should not be paired together because we can treat age-related hearing loss. We can address your challenges. And we're going to talk about that too. So what may be involved, keeping in mind, I'm not a physician. Case history, obviously, we're talking about long-term sustainable information, physical exam, cognitive testing, and the cognitive test used is going to be really important. Brain imaging, but again, guys, look at this list. There's a lot that could also be going on. And then laboratory tests. This should be a comprehensive evaluation. This should be a real investment of time and not just a box check. Like go to the doctor, get a diagnosis, and move on. I love this chart. Dr. Hotaling and I were talking about this. We love this chart so much. This talks about essentially the risk factors that contribute to major neurological disorders, right? And the blue are the things that you can modify, right? And your physicians have talked to you about this. You know these things, right? Reduce obesity, reduce diabetes, minimize hypertension. None of this is new to you. You know those are good things. Preventing or treating depression is important. I would say the same thing for anxiety. Physical activity, minimizing alcohol intake. One article was saying in the US, I think it's 12 drinks a week. You should not be having that much alcohol. You'd be having a good time, but not good for you. Higher education. I want to tell you and anyone at home that this is a really important thing. You are here. You are choosing to show up. And you know what? I saw many of you last time. This is actually like a huge contribution to you keeping your mind active and thinking about things, asking questions and chatting with people in this class afterwards, sending emails to us, remembering, right, that we had a conversation 2 weeks ago. So valuable. Pat yourselves on the back. You did it. Preventing and addressing hearing loss. You're here. You're talking about it. This is so great. I don't think there's a too late. I firmly believe I don't think there's a too late. Addressing visual loss, and then increasing social contact. But all those go hand in hand. So if you notice the arrows in the blue boxes, they go up and down, right? Because if you start walking in the neighborhood or on a treadmill or on a track with your friends, you're going to increase social contact, likely reduce some of the other bad things like hypertension, cholesterol, and diabetes. These are a partnership. You don't just do one thing and tick it off the list. You do one thing and lots of things come off. And so what we're really trying to avoid is the sort of contributing factors to a major neurocognitive neurological disorder. Decrease vascular damage. We want to reduce the dementia neuropathology. We want to reduce stress and inflammation. There's a lot really behind that. And then build cognitive and brain reserve. And we've talked to you about all the things you can do. You can't change the aging process. That's going to happen regardless. But you do get to control quite a bit. And I want you to leave here today feeling really empowered. Like, I got this. You've got this. And sort of all of this leads. But if you see the errors are kind of all over the place, because again, doing one thing doesn't just impact that one thing, it impacts other things. Okay, so this I mentioned, and it's kind of hard to see. So I'm going to read some things out loud. But this is also from the Lancet article. And it's come out, they sort of look at this multiple years. So the first time I saw it was around 2020 when it came out. And essentially it talks about the things that happen early in life that can affect your brain, ultimately leading to these major neurocognitive neurological disorder. So less education, right? And then there are many things in the middle of your life. So these are estimated percent contributors that you can modify to help your brain. So hearing loss is on there. It is 7%. When I have patients that come in that are so terrified, right? Like, I have hearing loss, I haven't treated it, I'm going to get dementia. I was like, nope, that is not how this works. That is not how this works. 7% is a number out of 100, okay. But the neat thing is that if you address your hearing loss, you're also likely going to impact your mental health positively. You're likely going to want to be around other people, so you're going to increase your physical activity. And then you're going to reduce your social isolation. So when you treat the hearing loss, we're really talking about 15%. Now that's a number. That should be an empowering number. And again, if you're sitting here today, you feel like you have hearing loss that's untreated. It's not a magic wand. It's not everyone with hearing loss that's going to have dementia later in life. It just means like you can do it, and you can tick off several of the contributing factors by getting hearing aids when it's time. Air pollution's on there a lot, and I think we cannot necessarily modify that, but that is something for a larger discussion. And then polypharmacy, right? And so not to come off medications, but to have someone really helping coordinate your medications. This is so valuable. And again, gerontologists, this would be their job, right? Is to look at your medications and coordinate care. Your physician has a list of your medications, but they may be prescribed by multiple doctors. And you really need someone that's going to look at it and say, oh, you know what? This one's better than that one. Or this one deals with anxiety and depression. We don't need 3 medications for this. So treating hearing loss alone isn't what we're doing. We're improving access to sound. We're helping, hopefully, we're not magic wands. We believe therapists are amazing. Medication for depression is amazing, but we're hoping we're contributing to a more positive outlook. We're decreasing social isolation by you being able to and choose to be involved. And again, addressing that is really key because we were at a wedding. My cousin got married on Halloween. It was very fun. My mother-in-law was there and she was like, I just can't hear you. I just can't hear you. And she sat on her phone for the whole entire reception. Yeah, it was devastating. And again, guys, I'm an audiologist. Like I am her person. So this isn't you. This is just the stigma attached to hearing aids and hearing loss and being ready for that next step, Dr. Hotaling. She'll see me in my office later. And may increase physical activity if the reason for being more sedentary was due to communication difficulties, right? And so I love this. Walking, even malls open early so that you can walk indoors when the winter's terrible. I say treadmills. I kind of go flying off those things, so I'm not promoting that for anyone since I actually don't do that well. But maybe you didn't take classes at the gym. The music's too loud and you can't hear the instructor. I want you to feel empowered to say, hey, is there a class where we can turn the music down for people who really need a better access to the gym instructor? We talked about treatment last time, but I want to go over it again because the feedback was this was really positive and empowering to you. And for those of you that are new, that are just meeting us, becoming our new friends, I wanted to go over treatment again because this is important. I want you to understand what's happening. So you need a diagnosis. You need to rule out other causes of listening difficulties. And we were talking about that. And we're talking about a medical cause, right? So cerumen impaction. So earwax, too much earwax, right? Impairing your ability to hear, which believe it or not happens. Fluid in the middle ear, like a cold where your ears get really filled up with fluid. So we do a full diagnostic evaluation to make sure that it is what we think it is, sensory neural hearing loss. Looking at the degree, which is how severe the hearing loss is, the type. So is it the outer ear, right? The middle ear, the inner ear, what's involved? And then the shape of your audiogram. So that actually tells us quite a bit of information. I can almost look at an audiogram and know if it's likely genetic or something else because just of how it looks. We can tell if someone has noise-induced hearing loss just by how it looks. Dr. Hotaling cares for veterans in our clinic, so she sees a lot of the veteran referrals. So lots of noise exposure from that. And it doesn't always look classic, especially when you add noise plus aging, but there are configurations that are really helpful for our treatment and our sort of long-term plan. Speech and quiet is always done. We really feel strongly that speech and noise should also be done, right? Because how many of you do just fine and quiet, and then you go into an environment with even a little bit of noise and it all breaks down? So speech and noise is honestly more telling of how you function day to day as opposed to speech and quiet.
So we talked about age-related hearing loss, and honestly, age-related hearing loss begins in like our 20s. So it's a long time thing. Interestingly, and you probably wouldn't be surprised, we're seeing younger people having hearing loss sooner in life. There's one major reason. What is it? Totally, earbuds. And they don't listen to it quietly, right? So the sound's really close to their ears and they're listening to it loudly. So they're doing their own thing. So it does begin early, and and like we mentioned earlier, it's very gradual. So over the years, we might turn the volume up on things just a little bit more. We may ask one more person to repeat themselves. So that time period of when did it really begin and when did we notice it and when do we do something about it is years. It's a lot of years. So I think the average between noticing and getting something taken care of is like 7 years. So it's a long time, right? So how many of you have seen what this chart? Okay. Okay. So this is an audiogram. It's a graph of your hearing. This is how, when we test you, this is how we notate the quietest sound that you can hear at different frequencies or different pitches. So as you go across the top of the chart, we go from low pitch to high pitch. And then down the side, we go from soft sounds to loud sounds. The circles are your right ear and the X's are your left ear. So this particular patient, their ears are quite similar. And with age-related hearing loss, that's usually what we see. Our ears are going to age at the same rate. We may see some differences. So I see differences with the veterans. Sometimes the one of the ears will be worse, and I will ask them, which ear do you, which hand do you shoot with? And it's always the opposite. Oh, I'm a right-hand shooter. So the left ear typically is worse. But we usually see similarities between the two. As you can see here, those higher pitches, those higher frequencies, our ability to detect the sound is worse. So we need more sound to be able to detect. The gray area is considered within normal limits. So when we talk about configuration or shape, this is a very typical configuration of age-related hearing loss. And that, if we see that, then we can tell that, okay, this is probably what is going on. You see those little carrots? That's when we test. If you remember from your testing, we put something behind your ear and presented the beeps. That's bone conduction. So if it's a permanent sensorineural hearing loss, that should match the circles and the X's. If this person had fluid in their ear, those carrots may be up in the gray area more. So that tells us what type of hearing loss we're looking at. That's it. Yes.
I just want to share this information again, and we were talking about it, but a couple important notes. So an audiologist has a clinical doctorate. So you will see an AUD after their name. They may have a master's degree if they graduated before 2007. I have my PhD, but have my clinical certification. So you would see that as well. Audiologist is the primary diagnostic person that you would see. We do comprehensive testing. We are trained in balance and hearing, but also disorders of hearing. So I've had people come in who have seen other professionals and they have like an actual medical pathology and need to be referred appropriately. And so we strongly encourage you to see an audiologist. There are hearing instrument specialists. They have a high school diploma. They are trained to fit hearing aids. They are not necessarily trained beyond the circles and X's to do any other test. They should not see anyone who has a medical pathology, but they're not trained to identify those. I'm not sure they would even know that they were looking at one. So I put a little caution on there just so you know who's seeing you. And I want to tell you that my dad, who we talk all the time, knows exactly what I do, had to get an updated hearing test so that I could review it. He's in South Carolina. It was the worst graph of hearing I've ever seen in my life. And I'm like, who did you go to? And he said, an audiologist. No, he saw a hearing instrument specialist. So I want to put that out there. Some are fantastic. Some audiologists are terrible. Know who you're working with, I think, is an important note. It's kind of like physician and PA. Everyone has their place in the system, but just know who you're interacting with. I want to talk about this, and this is the first time I've ever, in really 20 years, ever mentioned this, but I think it's really important. University settings have more extensive test batteries and more thorough evaluations. And lucky you have one, how far? An hour away? That's a little bit of a trip, but come and see us. But I would say the same thing in Mount Pleasant. There's an audiology program there, and Wayne State in Detroit, right? I equal opportunity for universities. We just have more, and we tend to be more thorough because we're training experts in this area. In Kalamazoo also has a clinic, even though they don't have an AUD program anymore, and they're great as well. ENT practices will often focus on medical treatment. So many of our patients, you went to see the ENT for something else and they tested your hearing. This is great, but they're really looking for medical causes, right? I mean, it's a doctor's office, a physician's office. Private audiology practices, so you see, like Gen Smart Hearing, is usually a private practice. The audiologist runs it. Their goal is going to be amplification or hearing aids, right? They want to be able to fit you with hearing aids. And so those are kind of the three largest pockets of places you would see an audiologist. You might receive, and I'm mentioning this to you just so that you're aware, sometimes our patients need medical clearance. And it may be that the ears are different when they should be the same. And I would refer you to a physician to make sure something else is not going on. And so the physician should do a physical exam, and in some cases, they should do imaging and MRI. And then they clear you to get your hearing aids. And that is to prevent you getting hearing aids, hearing better, but missing the medical disorder. You have amazing choices for your treatment. So the over-the-counter hearing aids were talked about, I think it was 5 solid years. But it was to provide you an option of $300 and not $3,000 to treat mild hearing loss. And I'm a huge proponent of it. You can purchase on you can purchase on the internet, you can purchase at Walgreens. I want to post this one note because this happened. I've had patients who spend $300 on Amazon on over-the-counter hearing aids, love them, but want something better. And so they come in and get hearing aids, right? You should not be spending $2,000 or $3,000 on over-the-counter hearing aids. At that price point, come to our clinic, get hearing aids. Over-the-counter hearing aids should be, $300 is still a lot, but affordable. And they're intended to be essentially amplifiers that are somewhat customized, but not what we could do, right? And it's a great thing. I love them. Get over-the-counter hearing aids. But if they're not enough, or if you notice a benefit but want something more, come and see us. Come and see an audiologist. The trick with hearing aids, which is very frustrating for all of us, is that hearing aids are not covered or poorly covered by insurance. So someone tells you it's $6,000 for a pair of hearing aids. I don't have $6,000. My husband and I have great jobs. I don't have $6,000. So it's tricky. And then your insurance covers it, but kind of covers it. And then there's barriers to get them. And then you don't know who to trust. Like this recommendation, I tell every person in my life, you can go to whoever you want, but just like touch base with me. Maybe we'll chat about it. There's different levels of hearing aids that you can get. We talked about this last time, but most of you entry level would be fine. There's only a few cases we would ever tell you to buy the Mercedes-Benz of hearing aids. Hearing aids plus assistive technology. So I could be wearing a microphone right now and speaking directly to your hearing aids. I would have put that on. It helps make my voice clearer. So in a restaurant that's really noisy, go, but it's really nice to have a partner mic so that the person's primary signal is actually the person you're talking with. I think that one is the most fantastic. And a lot of the hearing aid companies just throw it in with your hearing aid purchase, which is great. Cochlear implants are covered by most insurance companies. There are some that do not cover cochlear implants, so be aware of that. When hearing aids are not enough, sometimes hearing aids are not enough, and cochlear implants are a great option. A couple caveats, and I remembered this time, and I didn't mention it last time. If you have a VA, if you are a veteran, they do cover hearing aids if you have a rating for that. So if we see a veteran in our clinic, I always send them there before even talking about hearing aids because they will get them for free. The question is, how is their diagnostic capability at VAs? It should be excellent. It should be excellent. I've only ever worked in an active duty hospital. So at the Naval Hospital on the East Coast, it was excellent. Yes. And we have several VAs here. Our students go there and the care is good.
I know the one in Battle Creek, the one in Wyoming, Cadillac, not Muskegon too, because I think we have somebody going there. They do employ audiologists.
And we're starting to be our graduates are starting to be at most of them. So I would say excellent.
So we know they're awesome.
Just a quick comment. Medicare, and as a result, Medicare Advantage programs cover almost 100% of a cochlear. Medicare does cover, and Medicare Advantage must cover everything Medicare covers. So my $90,000 cochlear implant cost me $192.
Yes. It's yes, cochlear implants are covered well. Only when I came to Michigan did I see insurance plans that didn't exclusively said they do not cover cochlear implants. but in general, they should be covered. So thank you for that. A final thought, but like on a positive note, untreated hearing loss alone does not cause dementia. Untreated age-related hearing loss, that is causing difficulties in communication and therefore increasing the cognitive load of the conversation, and the impact on you will contribute to cognitive decline. We have time for questions. We're so excited you're here.
Well, you're going to do a handout too, in case that's a question, right? You have a handout
do.
there?
So
Yeah.
if you want to come and see us, last time, this was not about our clinic, but last time there were people that wanted to come and see us. So this time I did not remember, but Dr. Hotaling remembered handouts. So I have those for you if you're interested.
Okay.
I have a question about finding a place to recommend a hearing aid because I've only lived here for a year. I lived in Southern California for a lot of years, and I had my hearing tested there. But I was tested at a place selling one kind of hearing aid, and I couldn't get rid of the feeling that I was at a used car lot, and he was just selling one car. And I clearly have some hearing loss. I've had it tested here at an ENT. I don't think I need them yet. I'm resisting the signs that say I'm old.
That's
so,
okay.
But
No, so
is there a place that will
Yeah.
compare the different kinds of hearing aids and what's good for you?
So this is something, just being really transparent. Last time I was recorded, I was like, bleep. Being really transparent. I hate that feeling for you. It actually makes me really upset. We hate when a patient has bought hearing aids from Beltone and they come into our clinic and they want us to fix them. And guess what? We can't. So major hearing aid companies that you purchase from, we can adjust. If it's proprietary through even Costco, we can't adjust them. And so then I'm in a bind, right? I want to help you, but I can't. And you've just spent this money and you're unhappy. And the only alternative is to buy a different one. You're protected by a couple things. You have the right to at least a 30-day trial period. There will be a line item that says, I think in our clinic, is it $250? Our hearing aid trial fee, the non-refundable amount. Maybe it's $200. But there's a fee that will say non-refundable. But you can try the hearing aids and you may be like, I don't like these, Jen, I want to see a different one. And then we'll just try a different one. But that $200 is the only amount you don't get back. But if you spent $6,000, you get the $6,000 back if you don't like them and don't want to keep them. And that's law. I mean, that's to protect you.
So an audiologist would have access to different kinds of hearing aids. So you try one, I don't like this, they might give you a different kind.
They should. I will put that as a pause. They should.
The question, I mean, maybe the question for them would be, do you work with multiple manufacturers?
Yes, that's a great question. Do you work with multiple manufacturers, or which manufacturers do you work with? Beltone would be great if they were portable, right? Like we literally cannot, they will not give us access to update their hearing aids. So if you chose a different audiologist anywhere else that's not at Beltone, they cannot adjust the hearing aids. I know it upsets me every time. And not because the hearing aid's bad, just because I can't help the person in front of me.
I have a quick story. This is my own stepdad. He got hearing aids. All of a sudden, my mom calls me up again. They're in New York. Hey, he got hearing aids. I was like, no consultation? Like you didn't even ask, right? Okay. Went to Miracle Ear. Didn't like them, returned them. Okay. Fast forward 2 years later. Hey, he got hearing aids again because one of his friends got hearing aids and loved them and all the things, right? So I was like, yet again, no consultation, right? And then he says, I don't know about these domes. I can't get them. I cannot help you because they're Miracle Ear hearing aids and I don't have access to domes that will fit said Miracle Ear hearing aid. So yes, no consultation from the parents. It's so rude.
So
okay.
an issue I have with hearing is too loud, like at Hope College sporting events or flying in an airplane where my ears will ring for a day or two after that. So I have been using some ear plugs,
Mhm.
and they come in different dB ratings and so on. Could you comment on that? I mean, are they a good idea, and what dB do you recommend, or?
Okay, here's the deal. So that is typically what we would call hyperacusis, which is sensitivity to loud sounds. I typically caution my patients on overuse of earplugs. So on a plane is loud. Like I've measured it, it's over 90 decibels. It is loud. Wear hearing protection. Stadium noise is loud. I've measured it, it's over 110. It's loud. Wear hearing protection. If you find yourself even in an environment like this, or in a grocery store, or somewhere that is not loud. It's to you loud, but nobody else seems like it's loud. Do not wear hearing protection, because what you ultimately do is create even more sensitivity to loud sounds. So yes, when you're around a lawnmower, yes, at a concert, yes, with stadium noise, those are loud. And if hearing protection helps you, great. It's my concern is when people are using them when it's not dangerously loud, because then your body starts conditioning to want everything quieter, and then you can't function. And I have patients like that, and it's actually really difficult to treat. Related to the amount of dB, I think the what I've seen is an NRR. NRR is a noise reduction rating. 30 would be high. You're not actually probably going to get 30, but even 15 to 20 would be enough that you are feeling good. I would say, and I'm not sure what you would say, but if you feel comfortable in what you've chosen, even over the ear or in the ear, and they work for you, I think it's great.
I actually got my hearing aids at Costco, and we tried several different kinds. So I had a lot of trouble with background noise, and she said I was going to get the rechargeable hearing aids. And she said, I really want you to try this other brand with the other ones, because they really don't pick up as much background noise, and I think you're a lot happier. So she put one pair in. I went out in the store and walked around, came back, put the other pair in. I thought, you know what? I'm going to play with batteries, because it was just so much better. So usually places have more than one kind, and they can let you try different kinds. And if you have trouble with noise, go in a big store and walk around and see what it's like.
I love that Costco has you walk around their big noisy store. I do. Yes.
We have an online question real quick first.
Can tinnitus be treated, and can medication cause tinnitus? And I think you addressed that one earlier.
Tinnitus can be treated. I fell into working with tinnitus when I was getting my PhD, and worked in a tinnitus and hyperacusis center. So saw a range of different people. The treatment for tinnitus requires effort on your part, but it's really effective. The goal of treating tinnitus is to reduce the perception of sound, not to eliminate it. Medications can contribute to it, but it can also be due to hearing loss. So we typically test hearing. If we see a hearing loss, we fit with hearing aids, and a tinnitus management program is applied then. I wouldn't advocate anyone, every single warning, that's probably dramatic, but most of your medications are going to have a warning for ringing in the ears. And so I wouldn't start eliminating medications for that warning. I would say, let's look at the hearing and the tinnitus and see what we have going on. And there's someone who also, I think in this area, does tinnitus, the audiologist.
Holland Doctors of Audiology. Yeah.
Yeah. Yeah.
In your attempt to address EMND, do you rule out grief or complicated bereavement?
That is a great point. Yeah. You want to go take this one?
We don't, but that's a really good consideration, right? Because that sort of goes hand in hand with depression. Again, whether it's clinical depression or just depressed mood, I would see the two going hand in hand. And so that would be a good consideration, right? To sort of make, there's a lot too, just change in my stepdad, he was a big golfer. And when he developed his lung issue, he was unable to golf. And so then he didn't want to watch it on TV. And so that sort of led him down that sort of depressed mood of just, physically changing. And so I think it's a great point to sort of keep that in mind as well.
We do, just so that you know, I use case studies, and I think my colleagues do as well, related to major healthcare events, including loss of a spouse, or loss of a significant other. And we do talk about depression screeners. And actually just recently we talked about sort of being more open with suicide hotlines and access to psychology. So not necessarily just that factor, but we are trying to infuse it, so that it's a good point. Yeah, so the comment was, yes, it was more of a comment just saying not to put someone who's grieving into the depression category, right? Because it's a sort of a piece of the grief process. We do not counsel. If there is a something else going on, my students will not, I will not counsel related to grief or managing that. If there's any suspicion of anxiety, depression, anything, it's not ours, it's someone else's, but we support the recommendation. We may do screeners to refer accurately. That is a yes, but we would not, as a professional, should not actually touch that. So that is a good reminder and a good comment. I have to look up grief screeners. I don't know that I've seen those. So that's.
I mean, we talk about that too with parents of newly born children who are diagnosed as deaf. And most of those kiddos are born to hearing parents, and it can be quite traumatic. And again, ours is not to counsel them, but we know that in their stages of grief, essentially, they will walk through that to lead to hopefully acceptance and then advocacy for their child. So we do even, sort of look at it, but to Dr. Smart's point, we are not counselors, and we know sort of where our lane is. And that's why I always use this reference, and kids don't know it these days. Have like people in your Rolodex. Remember those, right? So have people that we trust to refer to.
So my question is, in your clinic, what do you do with a patient going through the cycle of life who goes from one set of hearing aids to another to another? In my case, I go through Holland Hospital's audiology department, and my perfectly good and almost brand new Phonak $6,000 P90 hearing aids, they would no longer accept them. They used to accept, but they no longer accept them. So I found a clinic in Zealand that would accept them, and they in turn reprogram them for somebody that can't afford hearing aids. So do you have a program like that in your clinic where, my last generation hearing aids can be reprogrammed and donated to those who can't afford them?
Yeah, so part of our goal with our hearing clinic is to serve also the having word finding issues.
Low income.
Right. Population. So yes, in fact, we just got an email from an SLP student who has a pair of hearing aids that she would like to donate to the clinic. And because they are programmable now and not as custom as they once were, right? They're behind the ear style. Yes, we can use them for loaners. So if patients come in and we have to send their hearing aids off for repair, we can give them loaners. So they're not without something for a week or however long it takes to repair. So yes.
I have a question. Being new, recognizing I'm having hearing loss, with an Advantage plan such as I have, I apparently have to go through some true hearing.
Oh.
What does that mean? That's discouraging me. Can I go anywhere I want to go with that? Or
So
how does
yeah.
that work?
Well, it doesn't complicate things in a bad way, but there are true hearing providers, and there aren't as many as we wish there were. We don't deal with insurance companies to keep our costs very, very low. So like a hearing test is $20 in our clinic. If we had to pay a biller, then everything sort of skyrockets. So we want to be a part of True Hearing to provide the care, but then we can't. So you couldn't come here and say, I have X. There are clinics that do True Hearing. One of my Sean, who was here last time, she used to in her clinic do True Hearing. You just, you can ask for a list or a referral from True Hearing, and they'll give you who provides it in your area. or you could say the greater West Michigan area, and then you'll have more choices. It subsidizes the cost of hearing aids, so it is a good benefit. We love the benefit for our patients. Yes.
Well, if there's no other questions, we really want to thank our presenters today for doing another great job and educating us about our hearing and what we can do now and in the future to improve it and keep our bodies well. And I thank everybody for coming. And she does have handouts up here if you'd like more information. So thank you all for being here. We really appreciate it.